anyway, I'm very sorry. Well, Mr. Chairman, ladies and gentlemen, it is my great pleasure and honor to be with you here today. And I'm going to address the luteal phase support. And of course, as you see, this is the treatment which you get when you are a chair of a meeting. You know, you get always the worst treatment. So, you know, I accept that so long it doesn't happen to any one of our guests. So that's fine for me. The topic is luteal phase support because I think it is very important topic, and I'm going to talk orally till they fix the presentation. Well, it is extremely important, of course, because we do know that it is important for the continuation of the pregnancy. When we look at the luteal phase support in the early part till the 6 to 8 weeks, it is being performed by the corpus luteum. So when pregnancy occurs, the corpus luteum becomes the corpus luteum of pregnancy. But after the 6 to 8 weeks, then the function of the corpus luteum is taken over by the placenta. However, it had been shown that when you are doing stimulation, then indeed there is a luteal phase support because of the decreased secretion from the granulosa cell retrieved from a stimulated cycle, whether you are using GnRH agonist or you are using GnRH antagonist. And that's why there is a need for luteal phase support when you are performing IVF. And having said so, then you would think that the need for the luteal phase support is important to improve the implantation rate and improve the pregnancy rate and finally the live birth rate. It also had been shown that there is a defective function of the granulosa cell in patients with PCO as well. So these patients, PCO, even when they are ovulating, there is dysfunction and dysregulation of the production of progesterone by the luteal phase. And this had been supported by studies in vivo as well as in vitro. And this actually highlights the importance of the need to give luteal phase support. Now, what types of luteal phase support can we use? Well, there are different, of course, regime. The old people sitting in this hall, as myself, remember the good old days when we used to use the HCG, 1,500 to 2,500 unit, starting after the embryo transfer every third day. But of course, we understand that giving this HCG had exposed us to a number of ovarian hyperstimulation syndrome, which was really our nightmare. And then that's why then, of course, people started to think about the use of progesterone as compared with HCG. And meta-analysis had shown that when you are using progesterone, whether injection or vaginal, versus the HCG, then you are having almost the same pregnancy rate. However, the ovarian hyperstimulation is 20 times higher in patients receiving HCG than patients who are not receiving HCG. And this, of course, is an important indication for us that progesterone is being preferred to giving HCG. Then what sort of progesterone are we going to use? We have been using different types of progesterone. Well, of course, the intermuscular, 50 milligram intermuscular every day, or the vaginal cream or gel, 90 milligram every day, or the vaginal capsule, 400 to 800 capsule in divided doses. And studies had shown that comparing these different regime for stimulation of for luteal phase support, whether you are giving injection, you are giving vaginal gel, you are giving the gel or the capsule or the vaginal capsule, you are getting the same results. So there is no difference between all the three preparations. And then recently, a few years ago, we had the subcutaneous injection, because we do know that with the intramuscular injection, there are problems of pain, discomfort for the patient, etc. And that's why the subcutaneous, aqueous subcutaneous injection is now being preferred. However, thinking about the cost for the patient, certainly this has to be considered when you are prescribing it. Then we come to what luteal phase support are we going to use? Well, of course, progesterone is the ideal one. But what about if you are using GnRH agonist, GnRH antagonist protocol? If you are using GnRH antagonist protocol, then there is a place for modification of the regime, which I have been saying. Some people had used the GnRH analog in small doses, 0.1 milligram, giving every day, 6 days after the embryo transfer. And it had been shown that when you give this low dose GnRH analog in GnRH antagonist cycle, then you have improved live birth rate. And we did at the Egyptian IVF, did a prospective randomized study comparing giving GnRH analog in GnRH antagonist cycle, 0.1 milligram every day, compared with long protocol, compared with GnRH antagonist protocol, not giving them GnRH. We stop the GnRH analog at the day of HCG, and we give them progesterone. Both groups, we give them progesterone. And in that study, we did not find a difference in the live birth rate and the ongoing pregnancy rate till 20 weeks between those who received repeated doses of GnRH analog versus those who did not receive GnRH analog. I must say that both groups received the progesterone as well support for this cycle. So when we looked at the literature, in the literature there had been a systematic review indicating that if you give GnRH analog for stimulation, for luteal phase support in long protocol and GnRH antagonist protocol, then you have improved pregnancy rate and live birth rate. So our explanation for this is that if you are using GnRH analog for luteal phase support in antagonist cycle, you may have improvement of the result. But if you are using it in long protocol, you are not likely to achieve result, as we found in our study. Why? Because if you are using GnRH analog long protocol, then the receptors, the GnRH receptors are saturated, and consequently you don't have the positive effect on these issues. So whether to give the GnRH analog for luteal phase support or not to give it, it is preferable if you give it in antagonist protocol, but not in agonist protocol. And then the other modalities, of course, for the luteal phase support is a small dose, repeated small dose of HCG. Some workers have suggested that if you give 125 international units of HCG in the luteal phase, because it is a small dose, 125 international unit, then you can get away without ovarian hyperstimulation. However, still ovarian hyperstimulation occurred in some cases. That's why they recommended that it is better in these cases that you do serum progesterone, and if you find it below the level of 30, then you give the HCG. If you find it above 30, then it is better not to give HCG, because this may result in ovarian hyperstimulation. So we come to the fact that in IVF, there is a luteal phase support. In IVF, you have to support the luteal phase. The way you support it, progesterone, of course, in the first place with its various types, with various modalities. And then, of course, there is a place for small dose of HCG, and there is a place for the use of the GnRH analog in a GnRH antagonist cycle. Then we come to the important part about the luteal phase support in the frozen embryo transfer. studies, international studies, had shown that today around 66% of all transfers are being frozen embryo transfer. So this is an important group which we really give attention to. When we looked into the literature concerning the TFS support in frozen cycle, then you have three modalities. The first one, either it is a natural cycle, or it is a modified natural cycle in which you control the HCG, you control the ovulation by giving exogenous HCG, or the or the HRT cycle, or stimulated cycle. So you have either stimulated cycle, or you have natural cycle or modified cycle, or you have the HRT cycle. When we looked at the literature, there were controversial studies. Some studies showed superiority of the HRT cycle on the superiority of HRT cycle on the natural cycle. Some studies show the opposite. Well, I'm almost finished. I don't want to waste time, so I think I'll go ahead. So the studies had shown that some studies were pro, that you give HRT cycle, you get better result. Some studies showed no, in natural cycle, you get better result. However, later on, meta-analysis had shown that there is no difference practically between the HRT cycle or the naturally stimulated cycle. Now, when you come to the naturally stimulated cycle, it has been shown again, prospective studies had shown that giving progesterone in natural cycle or modified natural cycle, where there is a corpus luteum, by giving progesterone, you improve the implantation rate and you improve the live birth rate. So the consensus of opinion is that if you are using a natural cycle, then you do need to give progesterone in spite of the fact that there is an already corpus luteum. But certainly, if you are giving HRT, then you will have to give the progesterone. Also, there have been some studies about adding estrogen estrogen to progesterone, whether it improved the live birth rate. But again, studies had shown that by adding estrogen to progesterone for the TFS support, it does not improve the result. So the consensus of opinion that there is no need to add estrogen in addition to progesterone. One word about the progesterone and the TFS support in the frozen cycle. It had been shown from the Swedish registry that if you do a follow-up of the children born after luteal phase support from natural cycle versus those with HRT cycle, then in those who received natural cycle, frozen embryo transfer with natural cycle, there is less antepartum hemorrhage, postpartum hemorrhage, pre-eclampsia, and other complications of pregnancy. So if you are using natural cycle or modified cycle, you are having less complication than HRT cycles. So why is this? And this is because when you are using natural cycle or modified natural cycle, you are having the corpus luteum. If you are having an HRT cycle, there is no corpus luteum, and consequently, you deprive the patients from all the good advantage of having a corpus luteum, like angiogenic factor, lytic factor, prostaglandins, and all these elements would be missing from patients receiving a frozen embryo transfer with HRT cycle. So the consensus, the opinion now, is that it is better to do frozen embryo transfer in a natural cycle or stimulated cycle. And when you do this, you do need to give as well progesterone in order to minimize the incidence of complication. One last word about the PCOS. Of course, we know that, as Professor Abdelmajid very elegantly had demonstrated, that in PCOS, then we resort to frozen embryo transfer. Yes, it's true, but be aware that studies also had shown that when you do frozen embryo transfer, in PCO patients, you are increasing the incidence of macrosomia in singleton, and you are increasing the incidence of preeclampsia in twin pregnancy. So this is the risk which we have to bear into mind when we are offering this policy, in order to be honest with our patient, in order to really have good counseling with our patient. I think with this, Mr. Chairman, I can conclude that in ART cycles, definitely there is a luteal phase insufficiency, and we do need to support the luteal phase. Whatever progesterone you are using, intramuscular, gel, subcutaneous, they are all the same. And if you are using GnRH antagonist cycle, then there is a place for repeated small doses of GnRH analog in order to, because it has been shown that the GnRH analog may have a positive effect on the endometrium and also on the quality of the embryos. Furthermore, it may improve the function of the corpus luteum through the LH effect and FSH effect, which are produced in these cases. Finally, when you are doing frozen embryo transfer, certainly you do need to provide luteal phase support. Luteal phase support can be achieved through a natural cycle or modified natural cycle with the addition of progesterone. I think with this, Mr. Chairman,